Your newborn son has just been diagnosed with hypospadias. You've been told the opening of his urethra isn't at the tip, it's somewhere along the shaft. And now the word surgery is being thrown around before you've even had time to process what any of this means. Stop. Take a breath. Because what you do with the next 10 minutes of information will shape your son's future more than any diagnosis ever could. Let me walk you through exactly what hypospadias is, why surgery is recommended in most cases but not all, what the procedure actually involves, and the one decision timeline that catches parents off guard every single time. Let me share a clinical scenario based on real medical experiences. We'll call this mom Rachel. Rachel gave birth to a healthy baby boy named Leo. Perfect APGAR scores. Perfect weight. But during the newborn examination, the pediatrician noticed something. Leo's urethral opening wasn't at the tip of his penis. It was on the underside, about halfway down the shaft. The foreskin also looked incomplete, what doctors call a dorsal hood. The pediatrician used the word hypospadias and recommended a consultation with a pediatric urologist. Rachel did exactly what most parents do. She went home and searched, and within an hour, she was terrified. She read about failed surgeries, about fistulas, about boys who needed multiple operations. She read comments from adults who said they wished their parents had never consented to surgery. She found other adults who said they wished their parents had done it when they were infants. Rachel was paralyzed by conflicting information. And that paralysis almost caused her to miss the optimal surgical window. Here's what Rachel didn't know then, but every parent needs to understand now. Hypospadias is one of the most common congenital conditions in boys. It occurs in approximately 1 in every 200 to 300 male births. That means thousands of boys are born with this every year. The condition happens when the urethral folds fail to close completely during fetal development, leaving the urethral opening somewhere other than the tip of the penis. There are 3 things a pediatric urologist evaluates when assessing hypospadias. First, the location of the urethral opening. Is it on the glans? That's the head of the penis, which we call distal. Is it along the shaft, which we call midshaft? Or is it near the scrotum, which we call proximal? Second, the presence of Chordee. This is a curvature of the penis, particularly during erection. Third, the appearance of the foreskin, which is typically incomplete on the underside. Now here's the first thing most parents don't realize. Not all hypospadias is the same. Not all hypospadias needs surgery. And this distinction changes everything about what happens next. Very mild distal hypospadias, where the opening is just slightly below the tip, sometimes causes no functional problems at all. The urinary stream may still be straight. There may be no Chordee. In these carefully selected cases, some families and surgeons choose observation over surgery. But here's the honest truth. These cases are the exception, not the rule. Most cases of hypospadias do require surgical correction. And the reason isn't cosmetic, it's functional. A child with an untreated hypospadias that opens anywhere other than the tip will have a urinary stream he cannot control. He will not be able to stand and urinate with a straight stream like his peers. As he grows older, this can cause significant psychological distress. Additionally, if Chordee is present and left untreated, it can cause painful erections in adolescence and adulthood. In severe proximal cases, it can affect the ability to have intercourse and to direct semen effectively for fertility. This is why pediatric urologists recommend surgery, not for appearance, for function, for quality of life, for the future that child deserves. The surgery itself is called a urethroplasty. Here's what actually happens. The surgeon uses the existing urethral plate and surrounding tissue to create a new tube that extends the urethra to the tip of the penis. If Chordee is present, the surgeon releases the tight tissue causing the curvature. The foreskin is often used during the repair, which is why circumcision is typically performed at the same time. For this reason, pediatric urology guidelines recommend that boys with hypospadias should not be circumcised at birth, because that foreskin tissue is valuable for the future repair. The surgery typically takes between 1 to 3 hours depending on complexity. It's done under general anesthesia. Most children go home the same day or after one night in the hospital. A small catheter is left in place for about 5 to 7 days to allow the new urethra to heal while urine is diverted. Now let me address the one question that every parent thinks but many are afraid to ask out loud. Will this surgery affect my son's sexual function as an adult? This is the question that kept Rachel up at night, and it's the question that deserves an honest, evidence-based answer. Long-term studies following men who had hypospadias repair as infants show that the overwhelming majority have normal sexual function. They have normal sensation, normal erectile function, normal ability to achieve orgasm and ejaculate. Satisfaction with sexual life is comparable to men in the general population. But I want to be transparent. No surgery has a 0% complication rate. The most common complications include fistula. That's a small opening where urine leaks from somewhere other than the tip, which occurs in about 5 to 10% of cases. Meatal stenosis, narrowing of the new opening, can also occur. Some boys may need a second procedure. These are real risks, and you deserve to know them. However, here's what the research consistently shows. The complication rate is significantly lower when the surgery is performed by an experienced pediatric urologist who does these procedures regularly. This is not a surgery you want done by a general urologist who does 3 of these a year. You want someone who does 50 or 100 or more. This brings me to the decision timeline. And this is where Rachel almost went wrong. The optimal window for hypospadias repair is between 6 and 18 months of age. Why this window? Several reasons. First, the tissues are at their most pliable and heal remarkably well at this age. Second, the child is not yet toilet trained, so the catheter and post-operative care are easier to manage than they would be in a toilet-trained toddler. Third, the child will not remember the surgery or the recovery. Fourth, and perhaps most importantly, by completing the repair before the child becomes aware of his body differences, you prevent the psychological impact of growing up with an uncorrected hypospadias. Rachel delayed. She was so afraid of making the wrong decision that she made no decision at all. Leo was nearly 3 when she finally scheduled the consultation. By then, he was toilet trained. He was aware of his body. The surgery was more difficult because the tissues were no longer as pliable as they would have been in infancy. The recovery was harder because he understood what was happening and was fearful. And the psychological impact of growing up different had already begun. Leo's surgery was ultimately successful. He's doing well. But Rachel will tell anyone who asks, don't wait. If you're going to proceed with surgery, do it in the optimal window. Get your consultations early. Make the decision while your child is still an infant. Here's your action plan if your son has just been diagnosed. Step 1. Request a consultation with a pediatric urologist who specializes in hypospadias repair. Ask how many of these surgeries they perform annually. There's no magic number, but volume matters. Step 2. At that consultation, ask 3 questions. What is the exact location of the opening? Is there Chordee and how significant is it? And does my son's specific case actually require surgery, or is observation an option? Step 3. If surgery is recommended, do not consent to newborn circumcision. The foreskin is precious tissue for the repair. Wait for your pediatric urology consultation before any circumcision decision is made. Step 4. Understand that the surgery is not an emergency. You have time. The 6 to 18-month window gives you room to research, to find the right surgeon, to ask every question you have. But don't let fear extend that window indefinitely. Step 5. Build your support system now. Connect with other parents who have been through this. Their experience will carry you through the pre-op anxiety and the post-op recovery in ways that medical facts alone cannot. Let me leave you with what I most want you to remember. Hypospadias is not your fault. Nothing you did during pregnancy caused this. It is a common developmental variation that occurs very early in fetal life. It is correctable. It is not a life-threatening condition. And your son will almost certainly grow up to have a completely normal, healthy life, including normal urinary function and normal sexual function. The surgery has excellent success rates when performed by experienced hands in the optimal window. The recovery, while challenging for a week or 2, is temporary. The outcome is permanent. Rachel's son Leo is now 5. He underwent his repair at age 3, later than ideal but still successful. He urinates standing up just like his friends. He has no memory of the surgery. And Rachel's only regret, she says, is the 2 years she spent paralyzed by fear when she could have been taking action. Your child's future is not defined by this diagnosis. It's defined by the decisions you make with accurate information and trusted medical guidance. If this video gave you the clarity you've been searching for, hit like. It helps other parents find this information when they're sitting in that same place of fear and confusion. And if you're the parent of a child with hypospadias, tell me your story in the comments. What do you wish you'd known at the beginning? Your experience could be the anchor another parent desperately needs tonight. Next, watch the video on your screen. It explains the single kidney diagnosis, what to do and what not to do in the first 48 hours. If your child has multiple diagnoses, that video is your essential next step. You are asking the right questions. You are advocating for your son. And that makes all the difference.